anyway, that we are going to have a different topic today. This is the better medical care through integrated care pathway, the way forward. So this is the outline of my today's talk. So before moving to that main topic, I like to share a few of my experience as a resident physician in this National Hospital Kandy over last 1 year period. So as resident physicians, we get quite large number of referrals across the hospital. Um, Most of them are very useful and we have to attend then and there. But among them, there are certain number of referrals that we get quite often, but they are not really needed at that, the inpatient basis. I will just discuss three of these kind of referrals which we commonly get. One is actually the hypertension management in the patients, especially in the patients in the medical, other than medical wards, those patients who admitted for various kind of problems. But we identify the blood pressure is marginally high, something like 150 upon 100, while on either single antihypertensive like enalapril or losartan. So we are asked to come to see the patient for the blood pressure management. When you ask from house officers in that particular board, what is the next step of management, normally they know what is the next management step because guidelines are quite simple. They know the next step. But when you ask why you refer this patient, that is sake of completeness, or as we don't have that particular protocol. Because of that reason, that the team always encourage to refer this kind of patients. But if we have that set of agreement or the plan, so probably we can avoid these kind of referrals. That doesn't mean that we have to avoid referrals, but may not be needed at that particular point. But the second example that I want to tell you, that we get quite large number of patients in especially in the surgical wards following following syncopal attack. But syncope itself is a broad topic that we had a nice lecture a couple of weeks ago. It is a broad topic, but still that large number of syncope is due to this vasovagal attacks, reflex bradycardia things. But what we need is actually the clear history about the antihypertensive management, or the patient's circumstances, what sort of things patient did, and whether there's a prolonged period of standing or sitting, or after a period of exhaustion like that. If we get this history clearly, we can judge most of the single syncopal attack probably due to reflex bradycardia or vasovagal. So not each and every syncopal attack needs a referral as an inpatient, but of course there are some some patients with syncope which need extensive investigation and management. We may need the electrophysiology studies, neurological study like tilt table test and all these things. But if we have an agreed plan, or these are the symptoms that we need to elaborate, if it is there, that we have to refer this patient then and there like that. Since we do not have that kind of plan, we have to refer this patient for the resident physician or the medical team. That is one thing. So the last example that I need to share, that is actually that we get patients referrals. Those actually are those patients admitted for this minor surgeries like cataract surgery or Avastin injection in the eyeball like that. But these patients, once patient admitted, suddenly we identify the blood pressure is high or blood sugar is high. That is actually just prior to that surgery or maybe the previous day. So our task is to either to see whether the patient is suitable for this surgery on the next day, or whether to postpone. But these I think that the patient get these dates. It's quite difficult because the waiting lists are quite long. If we suggest to postpone because the blood pressure is high and this is not an urgent surgery, they will need to wait another 3-4 months to get the next date. So if we have that previous assessment, at least if we can do a pre-operative assessment week or 2 weeks prior to this routine date, may be difficult because of this workload, but we should have some kind of assessment so we can avoid these kind of referrals. So these are the experience as resident physician in this large hospital. But having said that, I would like to come back to our main topic, that is about integrated care pathways, ICPs. Basically, this is a strategy for delivering consistent high quality care for patients with set of symptoms or conditions, sometimes conditions or maybe procedures. So that is the basic idea of what is integrated care pathways, and it also emphasizes the person's physical, clinical, and emotional needs for a specific condition. This is not as a holistic and not as a whole, but we address a set of symptoms or condition or the procedure. Uh, so this integrated care pathways, we can name it in different way. These all names, the list of names, probably with slight differences. This is the more same thing, like clinical care pathways, collaborative care plans, something like critical care pathways, especially the care pathways which we develop for this emergency setting or the ED setting. These are critical care pathways, like trauma-related care pathways, or anticipated care pathways like in palliative medicine, like care maps. All these things, probably the same meaning comes, and we can select whatever we like according to the situation. So this in detail, this integrated care pathway is a multidisciplinary process of mutual decision making that results in organized care of well-defined group of patients during a well-defined period of time. So we have to define certain things, like this is a multidisciplinary outline, because we know that we need the input from the many the disciplinaries for the patient's management. And there's an appropriate time frame. We define what is the time frame that we spend for this particular the condition or the symptom, and this helps a patient with a specific condition or symptoms, maybe shortness of breath, chest pain, something like that. And these pathways are based on best available evidence. So by doing so, this helps to deliver healthcare in a standardized and structured point of care format. So a few things about the history. If you see the nursing notes, especially in the places like NHS, even in our setting, they have a lot of tick boxes, and they have to check and tick the boxes, because we should not miss the things. So this is probably the origin of this kind of care pathway coming from this nursing notes. But first attempt was described in New England Medical Center in Boston in 1985. But little later in United Kingdom, they tried to implement these kind of care pathways. But the idea was to decrease the resource use without jeopardizing the patient safety and the clinical outcome. At that time, that it was the Labour government in United Kingdom. They wanted to cut down certain expenses related to this patient management, but without affecting the patient medical care. So the primary aims of this care pathways are actually standardize the practice and improve the interprofessional coordination, because sometimes that we have some argument between the couple of different disciplines or the professionals, because of this the ownership and all these things. But this kind of care pathways will improve, because we discuss and agreed for set of the plan. So, and also this import external evidence into local healthcare work. That is the important things about this kind of care pathways. So what are the features of this care pathway? So these are basically a bit of the theory behind this kind of care pathways. This is actually patient-centered. So we address the patient's individual needs and preferences, and also, as I earlier mentioned, this implement latest evidence. So we have to develop our care pathway based on the available best evidence. And this is a collaborative. For an example, if you get the stroke care pathway, how many the specialties or this discipline should be involved in these kind of pathways. And once we prepare these algorithms, then we have to do the detailed documentation about the process. And also, this kind of care path, if we have these things, it is easy for us to audit the process and clinical outcome. That is important, because no point of doing the care pathway and filling these forms, but there should be a continuous assessment and audit them. Then only we can identify what are the shortcomings, where are the areas, what sort of improvement we should do later. So when it comes to this criteria, common criteria of clinical care pathway, as we already discussed, it is a structured multidisciplinary plan of care. And It aimed to standardize the care for specific clinical problem or the procedure in a specific population, and to translate the guidelines into the local practice. So when it comes to that standardizing the care, but if you think about this dengue management about a couple of years ago when we were registered in 2007, 9, like, so we did not have that, not a single way of approaching the patient. Even the hospital, there may be variation. Even in the same hospital, from unit to unit, there are variation in the fluid management and things. So, as a result of that, because we did not have the correct guideline at that point, so we had a lot of issues related to fluid overload, effusion, and ascites and things. Then comorbidities and morbidities also varies from unit to unit because we did not have that kind of the agreed plan. Now, if you get either Peradini or Kandy or other hospital, more or less the management plan for a dengue patient is more or less same. We know that there's individual variation, but the outcome also quite similar because we have already agreed to the set of plan. I mean that we have a guideline is quite simple. That guideline can be applied the same way into our setting because these are simple guidelines. So this is actually important thing about implementing kind of a care pathways. So as we mentioned that guidelines, those are not always simple. We can't do the practice guidelines in clinical practice in most of the occasions. It is this integrated care pathway is a tool to incorporate local and national guideline into everyday practice. That is a process through the process called clinical governance. So not all guidelines are easy to apply in our setting. So few words about this, what is called this clinical governance. I will not go into great detail. This is a structured thing in a place, especially like a health sector, like even in our setting, our hospital, maybe especially in places like NHS in United Kingdom, they practice what is called this clinical governance. This is actually, if you simplify it, there may be 6 components in this particular thing. If you list out there's education and training, then the clinical audit, that is a very important thing, auditing these things, outcomes, then the clinical effectiveness. So even this integrated care pathway can be incorporated into places like this clinical effectiveness, then the research and development, openness and risk management. So what are the key things for the success of these kind of integrated care pathways? So we should have a good clinical leadership. It is not only the clinical, but also the administrator, medical administrator. Both clinical and the administrative leadership is a basic requirement. Otherwise, we can't maintain these kind of pathways. And there should be a feeling of ownership by the staff using the pathway. If we develop a pathway and just go and introduce to a different team of staff, they don't like to accept and do because it is not a simple thing. We have to do additional things. But if we can incorporate the staff members to development process of this clinical care pathway, that is one factor for the success. And there should be a team dedicated to development of this pathway. And more importantly, there should be education, information dissemination. That has to be there throughout. So then, by doing this clinical care pathways, right? Yeah, that's okay. I think there's something that I can't control. That's all right. I think probably we can just slides our right now. So by doing this clinical care pathways, we know that what and when should we refer. Not each and every patient to be referred, but if we have the early diagnostic plan, we know, and where and to whom should we refer to get the best outcome. In some occasions that we get the referral, simultaneously we get a referral for the same patient or the same clinical problem, the referral for two specialties, medical team and the neurological team. But the private problem is the same, so I'm not blaming anyone. But if we refer at the simultaneously for the same problem, I don't think you are going to get an additional benefit. So these things can be avoided if we agree for this kind of pathway. Right. So what are the advantages of ICPs? So as we this primary focus is something related to the time frame. So it decreases the length of hospital stay. That is quite useful. And this provide coordinated care between departments and patient care units, and standardize the patient care and reduce the variation, because it is well now it be evident that actually that dengue guidelines now it is practicing everywhere, and now we don't have additional fear of sending the patient to one particular unit, because it is managed in the more or less same in each unit, same wherever in the country. And this convert typical inpatient procedures into outpatient procedure, like this upper GI and lower GI endoscopy. If we have that agreed plan, some of the these kind of procedures can be safely arranged as an outpatient without much of the difficulties, and this improve efficiency and reduce hospital cost. So this hospital cost, probably we don't take it as serious, but if we have a good bed management system in the hospital like in NHS, so it is very important. We can't keep this patient days and days, because we have to clear the bed. For that, we need to arrange the discharge plan as early as possible. These are the advantages of introducing ICPs. So what are the disadvantages? Do we have? Yes, anything that we can have the negative point as well. This can be as workforce related challenges and organization and system challenges. When it comes to workforce, it actually we need more people. So lack of professional medical staff may be a difficult thing in our setting, because even for this the documentation and things, it is not easy that we need. Obviously, it increase the workload of the staff. Because of that particular reason, there may be resistance coming from the team, because we know that there's a thing resistant to change is something it is common in our setting, not only in the health sector, in many areas. We don't like to change. We think that what is available is the best, because the more changes are more difficult. So the resistance can be disadvantages in this case. When it comes to organizational and system challenges, there may be lack of shared understanding, and there may be conflict in organizational interest. So sometimes clinicians may be interested in developing a certain kind of care pathways, but the administrators, they might prioritize different kind of things. But the other main thing is actually financial issues and the lack of resources with technical and the technological and the challenges, like we need to get more IT and things. These are the disadvantages of developing this kind of care pathways. So the other thing is that in addition to this simple flow chart, that is the thing that we develop, that is for the daily practice, we should have a detailed documentation about the best available evidence for this care pathway and the limitation. It is quite important. For an example, if we do a care pathway development for stroke management, it is quite difficult, because if we do not have a separate CT machine for that hospital for this stroke management, the radiologist might argue, how can you do this care pathway without if you do not have the CT to do an on-arrival CT. These kind of limitations are there, but we can justify some of them, justification for any deviation from the national and international guidelines. If you have this detailed documentation alongside with the care pathway algorithm, that is that is also a requirement. So when I thought about what are the examples we can create this kind of pathways, so this is the list I just thought about. Chest pain, I think we try to practice our international guidelines in our setting, but it cannot be done as it is. And for an example, this upper and lower GI bleeds. So we had a lot of discussion about this ownership and the time of doing this upper or the lower GI endoscopy, because of this large number of patients and the limitations. But I think a couple of months ago, we had, I think the medical team, gastroenterology, GI, and the surgical team, they got together and discussed about the difficulties what we have when you have the patient like this. But I think they could not come to the final care pathway development, but a lot of discussions and a lot of agreement happened during this discussion. So that discussion itself gave us a lot of advantage, and now good understanding between team and there's no big issues related to this managing this patient. So these are the important things if we can develop. But in addition that, I think we should have a little bit of understanding about this palliative care and the end of life care management and pain management. In our setting, pain management is quite, I think it is not optimal. We have to do a lot of things related to this, and the management of sepsis. This is also important because it can be easily practiced, and the outcome is quite impressive. So from this point on, I will just go through a few of the care pathways which has already set in, and just as an outline. If you get the chest pain clinical care pathway, this algorithm or this chart shows us the management strategy for the non-STEMI SES. It is actually European Society of Cardiology guideline. So if you get this one, this is quite comprehensive. It is not easy for us to practice in our setting. So the things, the main things are actually what is the initial evaluation. We have to do the ECG on arrival and high sensitive troponin on arrival and 1 hour, and the result should be ready within 1 hour time. So some of the things we can practice, but not many. And then we have to validate the diagnosis and the risk assessment using RISCO and continuous rhythm monitoring for anyone who's suspected to have chest pain, and the BNP or pro-BNP. So in our setting, we may not be able to practice this kind of thing. This is, though it is not difficult, the resources are the limitation actually. Then we have to decide which kind of antithrombotic to be used. According to this guideline, aspirin we have to use for each and every unless contraindication. Then the second antiplatelet, whether it is prasugrel, ticagrelor, clopidogrel, that is normally decided by the cardiology team rather than the admitting team. So, but traditionally what we do is, along with this enoxaparin, we use aspirin and clopidogrel, because we don't go for this PCI and the primary intervention for most of this non-STEMI. So then we have to decide whether this patient for invasive or selective invasive, like that. There are steps to follow, and most of the patients should have either PCI plan or CABG, then hospital discharge planning with cardiac rehabilitation. So even the chest pain is quite common. Practicing this kind of guideline in our setting is not that easy. For that, I think if you think about our emergency department setting, these are basic requirements for us to develop a care pathway. We should have triage. We do have an OPD admission officer. He should have an idea about what should we do for the patient with chest pain. Then there should be a named healthcare assistant and the designated nurse for that particular shift to handle this chest pain related problem. Then there should be a designated area in the emergency department and immediate ECG facility, and there should be a doctor who is attending this chest pain and resuscitation facility. Some of them we have, but it is not it's not that easy. But this is actually we partly prepared one for our setting, because we can't practice that ESC guidelines for non-STEMI. So, but most of the things we can simplify and do in our setting. This is the on arrival what we have to do. If patient is unstable, we have to go for the resuscitation facilities. Then within 10 minutes, we have to complete ECG and the certain things, and we have to decide whether it is not STEMI. If it is STEMI, we have to go in a different path. Within 20 minutes, probably we can get the second ECG and decide whether it is cardiac or non-cardiac. Like we can do the things within the time frame. Then we can decide whether patient should go to cardiology unit or the medical unit, like that. This was this started to develop, but we practice these things. This is not new for none of us, but the thing is that we don't do it in a structured format. This is the other thing. Actually, I'm quite interested on this thing, end of life care pathways. This is as a part of palliative care. In our setting, we do not have this kind of pathway practicing. First, if we get this first care pathway for this end of life, is actually that is developed by this Liverpool University Hospital. It's called LCP, or the Liverpool Care Pathway. This was done in 1990s, This is to deliver good care to people through this in their last days of life. But what happened that later on it was well accepted, and this modified version start accepted and introduced to United States and European other countries and China and Europe. But as part of that, we have this what is called this do not resuscitation form, where that we have to determine what is the life expectancy, mental health capacity assessment, then the resuscitation state, and what are the treatment that we are going to withhold, and the communication with the patients or the relatives or their welfare attorney, and the doctor's signatures. So this, when we were there as the trainees in 2009 to 11, we had to sign these kind of forms for this unwell patient. So that has to be countersigned by the consultant within next 24 hours. So this is the care path they practiced earlier. So this is called this according in their last days of life, we have this symptom alleviation the plan. This is for the patient. The idea is to keep the patient symptom free. So these are the anticipatory medication that we use in this kind of end of life care pathways. In this end of life care pathways, we apply the ethical concept which is called this doctrine of double effect. So our intention is to keep the patient comfortable, but the adverse outcome is probably we get this the speeding up for the dying process. So this is actually ethically acceptable because our intention is correct, but we can keep their symptoms free using morphine, midazolam, hyoscine, and things like that. We are targeting pain, agitation, nausea, vomiting, secretions, and breathlessness. But pain management wise, this is quite useful. But later on, there was intense media scrutiny about the potential harm of these kind of pathways. Then they had to reassess this thing using a panel. Then they decide they identify certain deficit like poor communication with the family or the patient, and there's patchy senior decision making, and some patients were over sedated and denied food and drink. So these kind of pathways are quite difficult in our setting, but ultimately the panel concluded in the absence of reliable evidence of the pathway benefit, its use could no longer be justified. So after about 10 years, they discontinued it in around 2013. Later on, they developed another one that is called supportive care pathway. That is what now it is currently practicing. So I had the opportunity to work in a geriatric clinic in 2017 and 16-17. By that time, that has already changed. Now they have moved to this kind of pathway. It is more transparent and flexible. There's more room for the patient and the family to discuss about their preferences. So again, we have that kind of resuscitation form that is called a respect form, recommended summary plan for emergency care and treatment. Here the same things are discussed in detail, diagnosis, advanced directives. So sometimes patient comes with advanced directives, then we have to follow those things, and personal preferences, whether to prioritize the sustaining life or prioritize the comfort. Like that, there are certain areas like CPR decision, and also we should see whether patient has the sufficient capacity. If not, do they have a legal proxy like that? So we have to sign. This is more transparent and this is acceptable, and now it is practiced in United Kingdom, probably in the other countries as well. So after that, I just want to tell a few things about this acute stroke care part. This is something that we practice even in our hospital where the CT facilities are there. But the stroke part is quite, that is quite comprehensive, and it's not easy to practice. This is the example, because in 2021, I had a chance to work in a hyperacute stroke unit with the acute thrombolysis and acute stroke management, acute rehabilitation, and long-term rehabilitation. So when this is the stroke performer that they're practicing, So we have to time all the things like the suspected onset of stroke, at the time, what is the time of GP call, ambulance arrival time, stroke team alert time, and NHS assessment time, CT time, and like that we have to document. Not the doctor who document all these things. There's a team, this stroke specialist nurses has to document each and everything. So they can audit these things, and if there's any deficit, they will do the action to improve that. In this stroke performer, in the second page, there's a thing called this, we know that Rossier score, that is the recognition of stroke in emergency room. Because emergency doctor, they are not going to diagnose the patient as a stroke, but their task is to see whether this patient is someone with a possible stroke. So if this Rossier score is the plus one or more than that, then what you need to do, you have to alert the stroke team. So by doing so, they are trying to cut down the time that is going to spend for these kind of patients. And this is also in hospital, stroke thrombolysis using this fast code. So these things all are in the booklet. We have to see whether everything has been completed. Then the stroke team, that is the task of the stroke team to see this NIHS assessment. This is the initial time of assessment. Then whether this patient has the exclusion and the inclusion criteria. In case this patient is for possible thrombolysis, then we have to alert the stroke consultant and do the immediate discussion with the patient or the family within. Probably the idea is to start the thrombolysis within 20 minutes of the arrival to the hospital. That means within 10 minutes we should complete the CT scan, and next 10 minutes time we should get the over the phone report from the radiology team. Likewise, it is quite comprehensive there. So in our setting, if you try to apply this kind of practice, it's not that easy, but we can do according to what we have. So once we decide on this thrombolysis, there's a checklist not to miss any important thing, and also the doses of the alteplase or now tenecteplase also come into picture. They all, even the body weight and the dosing, everything is documented, because you don't have time to calculate and spend time on these things. These are the way that they have developed this pathway. Some patients need intraarterial thrombectomy and endovascular treatment. For that, there's a separate pathway for us to implement. So these are actually practiced in many parts. It says that even countries like Germany, they practice this pathways better than United Kingdom. So I just want to tell a few things about this, what is called sepsis care pathway. This is quite simple. I think we can do it as it is, because this is there are 6 components like oxygen, IV fluid, and the blood cultures, the lactate and other blood, and the urine catheterization and things, and output. These are very simple. We have to complete it in 1 hour of either suspected sepsis or diagnosed sepsis. This was developed by this United Kingdom Sepsis Trust in 2006, because they identify a lot of problems, morbidities related to sepsis. After that, they audited, and the outcome is quite significant and enormous. So this was well accepted, and now it is, I think it is practiced worldwide. In some occasions, not only for this kind of common things, some pathways have developed for this rare cases. This is for an example. This is a diagnosis and treatment algorithm for invasive fungal infection in neutropenic sepsis. This may be common in the places like oncology wards, but if we follow this pathway, we exactly know that what we had to do at that particular point. So this is another thing that I just put it here. These are the care plans for personal hygiene. This is done by the nursing team. For each and every patient who admitted to this geriatric wards should have this kind of thing. But in our setting, if you try to implement this kind of thing, it is not going to work. So we can't do that basically. Not everything can be applied in our setting, but we should select what are the things that we can apply in our setting. So not only for this inpatient management, certain things can be done for the outpatient. This is actually management of lipid in primary care that was developed by this United Kingdom general practitioners college of general practitioners, some of the trust in London. So this is for the identification of the risk related to dyslipidemia. So these things, if we follow that, we are not going to miss certain things. So I mean, so with this kind of pathway, we also had some effort to develop some of the pathways. This is one of them. This is called the lipid management for primary and secondary prevention of cardiovascular disease. This is not a complete algorithm. This was started a couple of months ago in Kandy and the Peradini team. We are trying to target the primary care, like primary care in this GP setting and the peripheral unit, district hospital, base hospital, then the secondary and tertiary hospital. So we are trying to identify the risk and at which level we have to treat. And not every patient should be referred to physicians or the endocrinologist, but we can do a lot of things before referring this patient. This is actually, it might come in the future, but at the moment it is in the developing stage. And similarly, there should be a care pathway development of diabetes as well. And the other one is actually the hypertension care pathway. So this is nothing new, but we are trying to apply the evidence or the guidelines, national and international guidelines, into our setting. So here we are trying to address the private sector, general practitioners, and the primary care doctors, then the secondary care doctors, then the base hospital and the tertiary hospital and the specialized unit. So in this third one, the algorithm, it is basically about how to step up the antihypertensive treatment. This has to be done at primary care level. So if we have that agreed plan for the hospital like ours, then probably we don't need to refer this patient for the medical or the resident physician for the hypertension management. It is very easy. So because these house officers, SHOs, registrar, they know what is the next drugs to start, but they do not do because they think that there may be a gap in this referring part. If you have an agreed plan, no need to refer this patient, but there are conditions that you have to refer, but not everyone. So these integrated care pathways are not a substitute for skills, knowledge, and expertise. That is one argument. Some clinician thinks if you develop integrated care pathway, this algorithm, ticks box and things, you are going to blunt your knowledge, skills, and things. It is not. It's basically the primary role of clinical care pathways to provide support for clinical decisions, especially to reduce errors, improve the safety, effectiveness, and overall outcome of the clinical care. So, having said that, I will conclude my lecture. It is quite a short one, but I think it is, in some extent, it should come into our practice in the standard way. Thank you very much for your patience listening.